talking about lab values and other things that are of interest to you after the presentation. So without further ado, let's give another warm welcome for Tina Maluso.
Thank you. I'm short. Thanks so much for having me. Welcome, and first of all, I really want to thank Anthony, who is your group leader and has pulled together all of these people that care so much about myeloma and has organized the speakers, including myself, to come here. Thank you, Anthony. You're wonderful.
Absolutely.
And today we're going to talk a little bit about understanding your lab values, which can be very confusing. And you wonder sometimes why it is that we need all of the things that we need and why we look at them so frequently. So I think that the important part is the more that you understand about them and the more that you begin to look at them and they become more meaningful to you, the more actively you can actually engage with your physician or nurse practitioner or all of your clinicians in helping to design your care and helping to understand your care and to understand the side effects, which is a very important part of treatment. To do that, we're actually going to start off with a little bit of the immune system. And the reason we do that is because many of the components of the immune system are actually what we're looking at when we're monitoring your myeloma, whether you realize that or not. And hopefully after this you will. And the importance of lab tests, and believe me, I understand how difficult it is to do the 24-hour urines and everyone's favorite bone marrow biopsies, which, believe me, we don't like doing them any more than you like getting them, but it's a very important part of giving information to us. And then we're going to go into the lab tests that are very specific for myeloma. And of course, we have to give a disclaimer. This presentation is not intended to replace the conversation you have with your own health provider. And your own health provider is the best person to give specific answers to you about your specific situation. Okay, I'm going to give some very general things. And of course, without knowing backgrounds and histories, giving very specific recommendations isn't possible. Okay, and with that, let's start off talking a little bit about the immune system. So when we talk about the immune system, what is it that we mean? The immune system in and of itself is a very complex network of cells and tissues and organs. Its basic job is to just keep you from getting an infection. Okay, that's the basic job of the immune system. Although ultimately it's very complex, in the way that we're going to look at it today, we primarily are going to talk about the white blood cells. White blood cells are created like all of the reds and platelets initially in your marrow. And the white blood cell precursors. Precursors is just the baby cells, from where they come. So there's B cells, T cells, and phagocytes. Those are primarily what we talk about when we're talking about the white blood cells. And when we look at the immune system, we generally divide it into two big types of responses. One of them is called a cellular, and one of them is called humoral immunity. Now, in cellular immunity, it's sort of the body's response to infection by the cells of the immune system within the tissues and organs of the body. And that part of the immune system is regulated by T cells, or T lymphocytes. That includes the neutrophils, which are the little white cells that you know surround and gobble up bacteria, and the killer T cells. Those are all cellular immunity. When you look at humoral immunity is a little different, and it's the way that the body responds to infection in the blood and the body tissues. So it's done a little bit differently, and it's regulated by the B cells, or B lymphocytes. Well, when B cells grow up and become adults, they become plasma cells. And plasma cells should sound very familiar to you. Those plasma cells secrete a protein that is actually an antibody that protects you from infection. Those antibodies, that protein is called an immunoglobulin. Okay? So the difficulty in myeloma is it's secreting lots of those immunoglobulins, but they're useless. They don't protect you from infection. And they crowd out the healthy ones that do protect you from infection. That's the basic problem. So when you look at antibodies, every antibody is comprised of 4 chains. So there's 2 identical light chains and 2 identical heavy chains. And these names probably sound very familiar to you, right? So the heavy chains are IgG, IgA, IgM, less commonly IgD and IgE. And then the light chains, which I'm sure sound familiar also, are kappa and lambda. So we all have heavy chains and light chains, and every person's antibodies have a little different combination of those things, with the heavy chains and the light chains. In myeloma, the type of myeloma is going to be named by the immunoglobulin. You may have IgG myeloma or IgA, along with whether the light chain is lambda or kappa. So, first of all, we're going to take a little bit of an overview of myeloma in and of itself before we start looking at the labs that are very specific to myeloma, so we can rather focus what it is that we're looking at, okay? And what is myeloma? Well, you all know this very well, I'm sure. It's a rare, though actually quite frequent, blood cancer that occurs in the B cells when the B cells transform into these cancerous plasma cells. These myeloma cells end up secreting, instead of a regular immunoglobulin, the M protein, or the myeloma protein, or the monoclonal protein. They're all the same thing, okay? So I think that, people will sometimes say, what's the difference between a monoclonal protein and the M protein? It's the same thing. So the myeloma diagnosis is given when there's a certain amount of this monoclonal protein that's found in the serum or the urine, or from our world in the bone marrow. And sometimes there are myelomas. Does anybody heard of a non-secretory myeloma, or does anyone have a non-secretory? Okay. There is a kind of myeloma actually that does not secrete. It doesn't secrete an M protein. And on those people, really the diagnosis is made by having greater than 30% plasma cells in the bone marrow, or a histologic biopsy of a plasmacytosis. And sometimes you'll hear people say, well, we looked at this and we thought you might have had a plasmacytoma. A plasmacytoma is just a large aggregate of a collection of abnormal plasma cells where they're not supposed to be. And you usually see them either in the bone or in soft tissue outside of the bone. And people may have them in place, so you end up biopsying it. We think it's a lymph node. We're getting them worked up for leukemia or a lymphoma, and it ends up being a plasmacytoma. And they end up having, a non-secretory myeloma, if there's the absence of the M protein. So signs and symptoms. The signs and symptoms vary, and in most people, part of the problem is that there aren't a lot of signs and symptoms early on. It's not until the disease starts to progress that you start to see signs and symptoms. Fatigue. And why do we see fatigue? Well, for a lot of reasons, but primarily you see fatigue from anemia. Low red cells, low hemoglobin. It's the hemoglobin molecule that holds the oxygen and takes the oxygen and circulates it around the body, through the brain. So it's very, very difficult to keep up with your normal activities of daily living if you don't have enough oxygen traveling around your body to do it with. Other bleeding abnormalities. A lot of people see easy bruising and bleeding, and that's because those plasma cells are reproducing very rapidly, and when they do, they take up space in the bone marrow. And if anybody, which many of you may have had Neupogen or other drugs in the past that may cause some bone aching, bones don't stretch very well. They are living tissue, but they don't stretch very well. So these myeloma proteins, these plasma cells, proteins, take up too much space in the marrow, and they begin to crowd out the other healthy cells that you need. One of them is platelets. So people's platelets will drop. Another one is their red cells. So red cells may drop. White cells may drop as well. Recurrent infections. And people get infections for a lot of reasons. One of them is the white cells may drop. Another one is, when we talk about humoral immunity, that's those immunoglobulins that are normally put into the system to help protect you from disease. When you have a myeloma, you're getting a lot of abnormal immunoglobulins put out there that are useless and protect you from nothing. Bone pain and fractures, and you know that's because it tends to attack the bones. Kidney damage. I want to talk for just a couple of minutes about kidney damage. I want to say, if anyone's early in treatment, I work with patients before transplant and myeloma, during the transplant and after transplant. We have people that come in who, at the time of diagnosis were very close to being on dialysis, and we even have transplanted people who are on dialysis. And much of that is reversible. In many of the patients, it's very reversible. The kidney damage is very complex in myeloma. It can happen many different ways, but the primary way that it happens is those free light chains. We don't really want them free so much. I mean, freedom's a great thing, but not for light chains. We kind of want them bound to heavy chains. We don't want them running around. They get stuck in the renal tubules and they cause damage to the renal tubules. They clog up too quickly to be able to allow the kidneys to clear them. And we have to be very, very cautious in anyone with myeloma. I never want to use dye on a contrast dye on a scan of any kind unless I absolutely have to. And most you really don't. And although people have bone pain, we really talk them, try not to use non-steroidal anti-inflammatories because, again, it's very difficult on the kidneys. You need to really watch those medications that are difficult on the kidneys because you've got these light chains. And that's why we're always on people about hydrate, hydrate, hydrate. Because if you don't hydrate enough, there's a greater chance that you're going to have some kidney function damage. The other thing that causes kidney damage is hypercalcemia. So it's another reason that we have to get on top of the high calcium and get it under control. The sluggishness and constipation and confusion can also occur as a result of having high calcium in the bloodstream. And the calcium is that the myeloma is attacking the bone begins to break down, it releases this calcium into the system. Okay, so we're going to get into a little more specific conversation about how to look at the labs that are very specific to myeloma. We'll start off with some basic ones and then we'll focus it more into the very, very specifics. Please feel free to get up and get yourself something to drink, or you need the restroom, or to ask questions as you'd like. Yes, go ahead. Sure.
Kidneys with the GFR.
Mm-hmm.
When you see like just an inch is starting to be lower, it gets down to 63. Is that something to maybe see a specialist about?
It's a very good question. GFR is sort of one of those things that the glomerular filtration rate tells us basically what amount of fluid your kidneys are able to filter during any given time. 63 from my world is pretty good. We transplant people up to 50, so, and actually in myeloma we even do it sometimes lower. What is most important is looking at the trend. If you have a trend that's trending downward and your glomerular filtration rate is trending downward, then take a look at some things like, are there medications that you can stop? If it really starts to change, then we want to kind of take a look at, are there more light chains or are there more monoclonal proteins? Are we getting into a more active phase of disease? And hydration as well. But a GFR of 63, I'm happy with, personally. So before and during and after all of your myeloma treatments, which after myeloma treatment to me, I don't know that necessarily is a phrase that we use a lot. We look at myeloma as a disease on a continuum. It's when people come for transplant, frequently they think they're coming and they want to get a cure. First of all, in cancer, we don't use the word cure very much in any cancers. But in myeloma, what we're looking to do is get someone into a good remission. The best remission that we can get you into. A complete remission, if we can do that, and then drag it out as long as we possibly can. Until something else happens, and then we move on and keep on dragging that out until the day comes when, if there's anything that I would say to anyone who has myeloma or knows anyone with myeloma, is that the future for myeloma is very, very bright. I do want to let you know it has changed dramatically in just the 15 years that I've been doing this, and one of the physicians I work with is a very, very well-known myeloma expert, and she's actually represents America on the European Society of Clinical Oncology. So there are many things coming down the road. Take care of yourself, stay up on things. We have patients living much, much longer, and it is really seen now as a chronic disease, like any other chronic disease. So please, if you take nothing else away from this, the future is bright. So we look at all of these labs to be able to diagnose the disease, to determine the severity and the spread or the staging. And staging, I'm sure, gets very confusing, but those are just words for us to use with each other, really. To monitor disease progression and recurrence, to look at the effectiveness of treatment, and to look at prognosis. Although many of the things that we used as prognostic indicators have changed a lot over time as well, too, as new drugs, new treatments, new therapies have come on the horizon. We found that some of these are most effective in some of those poorest cytogenetic risk patients. So it changes a lot of things that we've looked at. And what factors affect your lab tests? Well, of course, age. I want to say, we give transplants to all kinds of people, related, unrelated, cord blood transplants, and now we're doing actually haplotransplants, meaning a parent or child. If you don't have a match in the worldwide system, we do parents and children. A 78-year-old who jogs 6 miles a day, may be healthy, and I hear the doctors present them all the time, this healthy, robust 78-year-old, which is wonderful, but they still have 78-year-old bone marrow. So bone marrow will bounce back much more slowly as we age. It doesn't mean that we're not going to make the cell lines, but as we age, our marrow stores become less robust. Okay? Race, gender, medical history, general health, having pre-existing diabetes or kidney functions or heart disease makes it a little more difficult, as you well know. Diet, specific foods that you eat, medications, and of course, techniques in labs. Remember that every lab has their own range of normal values. That's why they're printed there. So what is an abnormal at one lab may actually be a normal at another lab. I mean, I work for Kaiser, but we do all of the transplants for all of Southern California, Hawaii, and part of Colorado. So we have a wide group of patients. They'll have labs coming from all over the place, but at City of Hope, and all of the labs have different normal values. The range is similar, but it's not exact. So don't worry too much about upper and lower limit, especially between lab values. And you can't really take one value from a lab and compare it to another lab. You need to know their normals, okay? So what are some of the clinical features that we look at when we're evaluating myeloma? Number one, we look at calcium elevation. You see the little acronym CRAB, which we always think about when we're diagnosing myeloma. We're looking at and staging. C is calcium. Is the calcium elevated? If so, how much? It tells us a lot about how much damage has been done to the bone. But it's not just the calcium. We'll look at the alkaline phosphatase too. Two together tell us a little more about bone damage. R stands for renal or kidney. Is there an abnormal amount of monoclonal protein that has damaged the kidney, and in what way, and how much can we reverse that? A is for anemia, and anemia happens for several reasons. We'll talk a little bit more about it. One is that it crowds out the red cells. The other is if you begin to get more progressive kidney damage. The kidneys are where erythropoietin is released, and erythropoietin is the growth factor, if you will, for red blood cells. So as kidney function gets worse, it may actually affect your ability to make erythropoietin, which stimulates red cells. And bone abnormalities. So I'm sure you've heard the words osteoclasts and osteoblasts, and if you haven't, I remember them this way. Osteoclasts are the consumers, osteoblasts are the builders, okay? So we all have osteoclasts and osteoblasts in our bones doing their thing all the time. We all have bone remodeling going on in us all the time. But in most of us, the activity is rather balanced. In myeloma, what happens is that the M protein actually stimulates the osteoclasts, the consumers, to break down, and it kind of inhibits the osteoblasts, which are the builders, to build back up. So that's what happens, and that's why the calcium's released. That's why there are the bone lesions. So first there's the general lab tests. We're going to kind of look at the CBC, chemistries. We're not going to look at everything. We're going to look at just the things that relate specifically to myeloma. Beta-2 microglobulin, serum albumin, and then the myeloma-specific tests. The ones that, to me, I think, confound people the most, which are the protein electrophoresis, immunofixation, quantitative immunoglobulins, serum-free light chain analysis, and serum viscosity. Okay? So let's start with CBC, and this is a simple one, and you probably don't have a lot of questions about this, but we always have to look at your blood counts. Why? Well, we need to look at your red count for several reasons. We need to know why it is, if there's an anemia, why it is. Can we help to alleviate that, which may make fatigue a little better? White count, we want to look at white count. Low white count weakens a part of the immune system, you know that. And a very high white count frequently indicates infection to us. But do let me say this, sometimes people's marrow don't have the reserves to be able to mount a high white count in the presence of infection. So you can have an infection with a low white count that doesn't rise in the presence of infection as well. And then platelets, again, low platelets, you see a lot more bruising, more bleeding, you brush your teeth, you may see some bleeding with the toothbrush, nose bleeds frequently, small bumping of your arm ends up with a giant bruise. And then hemoglobin, which hemoglobin really is telling us how much of those red cell molecules are available to be able to carry oxygen around the body. And then a comprehensive metabolic panel. We look at a lot of things in a comprehensive metabolic panel. They've just chosen a few here. One of them is calcium, which I think we've talked about, tells us a lot about bone destruction. Creatinine. Creatinine is a protein that is released in response to loss of kidney function. And you probably all know we watch your creatinine very carefully. In terms of renal function, it's very, very important. And total protein. So total protein may be very high and indicate the presence of excess M protein in the bloodstream. The other one that I want to mention is that they don't have listed here, but I think it's certainly worth mentioning, is albumin. People look at total protein and albumin and think they're the same thing, though albumin is a protein. One of the most important protein carrier molecules of the body is albumin. And you'll notice that when your albumin's really out of whack, it's really low, it's hard to get other things under control. And that's because we rely on the albumin to take the thyroid hormone from where it's released to where it needs to be used. We rely on the albumin to take the insulin from the pancreas to where it is that it needs to be used. So you may have enough of the hormone, but if you don't have enough of the albumin to carry the testosterone or the estrogen or whatever the hormone is, you're not going to have effective utilization of any of the secreted hormones. So I think albumin is a very, very important indicator to look at as well. Beta-2 microglobulin, oh good, we do talk about albumin, that's funny. Beta-2 microglobulin, we measure, and I'm sure you probably all know what your initial beta-2 microglobulin was. If you don't, you're not missing anything, it's okay. Really. It measures a protein that's found outside of plasma cells. So the higher the beta-2, the higher we can assume is going to be the number of the plasma cells. High levels may indicate malignancy, such as myeloma. We really use beta-2 only as sort of a prognostic indicator. We don't look at it as closely to tell us about response anymore. But it is something that we'll check regularly. Albumin, I just talked about. It is produced in the liver. It's important to know that. Low levels may indicate renal failure. So again, if you're going into renal failure and have a low albumin and are a diabetic, it's going to be really difficult to get that insulin from the pancreas to where it needs to go because it doesn't have a carrier to get it there. You may also see when the albumin lowers, people's thyroid medicine needs change because, again, they don't have the carrier to move it. It is actually looked at as a prognostic indicator as well, to look at the prognosis long-term in myeloma. And serum viscosity. Viscosity just means thickness. How thick is the blood, basically? And that tells us something about how much of this abnormal immunoglobulin or protein is in the blood. So, myeloma specifically, first one is the serum protein electrophoresis. So whether it's serum or urine, this is what a protein electrophoresis typically looks like in someone with myeloma. So that it sorts and it divides out all of the proteins in the blood. That's what a protein electrophoresis does, by size and by electrical charge. So you end up, we get a graph that looks kind of like this. It's not as pretty as this when we get it. The first one is, you can see albumin, and then it fractionates it. Patients with myeloma generally have this classic M picture because they're going to have a really high spike of one of those immunoglobulins. That's it. That's why it looks like that. And it's used to diagnose and monitor it. After treatment, we want to see some of those hills become a little more equal after the first spike. Okay? And then there's immunofixation, which is also an electrophoresis. And that actually identifies the specific type of antibody that's produced by the myeloma cells. And it actually fractionates out its light and heavy chains. And we use this so that when the M spike is present, we want to know of that M spike in those, say you have an IgG spike. We want to be able to know sort of what percentage of those are absolutely useless and what percentage of those may be useful type cells. And it's used to diagnose and monitor, again, as they all are. Quantitative immunoglobulins is going to look at the whole picture. So it's going to measure each of our immunoglobulins. If someone says you have an IgA or an IgE or an IgM myeloma, you still have all of the other immunoglobulins. It's just that that one spike happens to be the one where you're making the abnormal immunoglobulin protein. But this tells us the whole picture, what they all look like. And it's very important because immunoglobulins are the body's humoral way of immunity, of taking the, say, when you're immunized, or you had measles or mumps, or as a child. Those things are held in memory in these immunoglobulins. This is how they attack them.